In this slide, we're going to present the etiology. So I'm going to start with the etiology of obstructive sleep apnea. It is primarily rooted in its anatomical and mechanical factors that lead to airway collapse during sleep. One of the most common causes is obesity, especially when there is excess fat tissue around the neck and upper airway, which physically narrows the pharyngeal space. Other structural risk factors are enlarged tonsils or adenoids or a recessed jaw or even a naturally small airway. These features make it easier for the airway to collapse when muscle tone naturally decreases during sleep, particularly in REM. Lifestyle factors like alcohol or sedative use, smoking, and sleeping in a supine position can also worsen OSA by relaxing that upper airway muscle even more. Age and male gender are additional risk factors due to differences in airway anatomy and fat distribution. Now, the cause of central sleep apnea is very different from OSA because it stems from the brain's failure to signal the body to breathe during sleep. Instead of a blocked airway, CSA is linked to neurological or physiological conditions that disrupt the normal respiratory drive. A major risk factor is congestive heart failure, especially with a low ejection fraction, because of its association with unstable breathing patterns, like Cheyne-Stokes respiration, for example. Other causes can be stroke, brainstem injuries, chronic opioid use, and high-altitude exposure. These conditions affect the brain's ability to properly detect and respond to changes in carbon dioxide levels, which overall throws off the normal feedback loop, and that triggers the breathing. And in many cases, CSA is associated with increased sensitivity to CO2 changes, which lead to the overcorrection and unstable breathing patterns. Now, our last one, mixed sleep apnea, is also known as complex sleep apnea syndrome. It has a dual origin, so it begins with obstructive events, but central apneas appear often during the treatment. Most patients are initially diagnosed with OSA and start using CPAP therapy, which effectively opens that upper airway. However, for some people, once the airway obstruction is corrected, their underlying central dysregulation becomes unmasked, and the central apneas actually emerge. So the exact mechanism isn't fully understood, but it is believed to involve instability in ventilatory control and overcompensation in CO2 regulation. Patients may have underlying conditions like heart failure or chronic opioid use, but in some cases there is no clear explanation, which makes the mixed sleep apnea way more complex than the other ones and a dynamic disorder that evolves during the course of treatment.